welcome to this lesson on neuromodulation and the functional dynamics of the central nervous system. Here, we will explore what it means for the brain to function normally, how dysfunction manifests, and how neuromodulation can be used to intervene therapeutically. By the end of this session, we will have a deeper understanding of the brain's ability to rewire itself and the cutting-edge technologies that leverage this ability to improve human health. The human brain is a marvel of biological engineering, capable of adapting, learning, and recovering throughout life. At the heart of this adaptability lies neuromodulation, the process by which the brain's neural activity is regulated to maintain balance and functionality. We should know neuromodulation is not just a scientific concept. It is a therapeutic tool that harnesses the brain's inherent plasticity to restore or enhance function in cases of dysfunction. To begin, let's ask, what does it mean for the brain to function normally? A functionally normal brain exhibits balanced brain waves, optimal cerebral blood flow, efficient oxygen and glucose metabolism, and well-regulated neurotransmitters activity. Such a brain can seamlessly organize its states, much like a healthy heart adjusts its rhythm to meet demands and returns to a resting state. A healthy brain is flexible, capable of shifting between states such as focus, relaxation, or sleep with ease. In contrast, a dysfunctional brain shows imbalances in brain waves, cerebral blood flow, oxygen and glucose metabolism, and neurotransmitter levels. It struggles to transition between mental states, often exhibiting excessive or insufficient activity in a specific brain wave frequencies or regions. Dysfunction of the brain can manifest in various ways, including cognitive symptoms that may have difficulties in thinking, reasoning, memory, and decision-making, motor and sensory symptoms, issues with vision, hearing, and movement, emotional and behavioral symptoms like mood disturbances, perception problems, for example, hallucination, and autonomic dysregulation, for example, abnormal heart rate. To visualize these imbalances, we use tools like quantitative electroencephalography. A healthy brain produces appropriate brain waves for each situation and quickly returns to stability. For example, fast brain waves of beta waves are normal during excitement but inappropriate when trying to sleep. The image below shows excessive beta and high beta activity in frontal region during an excited state, which normalizes once the person relaxes. And what is neuroplasticity? The brain's adaptive power. Neuroplasticity, first described in 1819, refers to the brain ability to reorganize itself chemically, structurally, and functionally in response to experiences, environmental influences, and physiological changes. This lifeline capability allows the brain to adapt, learn, and recover. At the core of neuroplasticity are synapses, the junctions where neurons communicate. Synaptic activity underpins our thoughts, feelings, actions, memories, and learning As the philosopher Descartes has said, I think, therefore I am. In the context of neuroscience, we might say, I learn, therefore I am. Descartes' axiom, I think, therefore I am, anchors existence in conscious thought. Translating this into neuroscience, I learn, therefore I am, offers a compelling reframe thought. From a neuroscientific lens, learning is not merely an act but a fundamental biological process rooted in neuroplasticity, the brain's ability to rewire itself through experience. Learning shapes synaptic connections, refines neural networks, and underpins memory, decision-making, and identity. Without learning, the brain stagnates. Cognition, behavior, and even our sense of self would remain static, disconnected from an ever-changing environment. Organisms incapable of learning struggle to adapt or survive, suggesting learning is intertwined with biological and existential resilience. Learning even persists in dementia, but manifests in subtler forms that is well observed. Neuroscience distinguishes explicit learning that creates conscious memory from implicit learning that creates procedural or emotional memory. In dementia, explicit memory, for example, recurring events, is impaired, but implicit learning remains intact unless in very severe cases. Similarly, sensory perception in infancy relies on implicit sensorimotor learning. A baby touching a hot object does not understand heat conceptually but learns through synaptic plasticity. Nociceptive pathways strengthen, creating an autonomic avoidance reflex. This learning and declarative memory shapes behavior and survival. Thus underscores that learning begins before self-awareness. Early sensory experiences scaffold cognition, shaping the neural architecture that later supports abstract thought. Without this foundational learning, consciousness itself would lack coherence. Learning in neuroscience is any enduring change in neural circuitry due to experience. This includes cellular plasticity, that is, synaptic strengthening, for example, long-term potentiation or weakening, system-level adaptation, reorganization of neural networks after injury, and metacognitive shifts, adjusting strategies to cope with limitations. In this way, I learn, therefore I am, holds provided we define learning broadly as the brain's dynamic capacity to encode, adapt, and persist through change. In short, learning is not binary but a spectrum of processes that sustain being, even when traditional markers of memory or cognition falter. Plants also undeniably adapt to environmental stimuli through processes that relies on cellular signaling, for example, calcium waves, electrical gradients, and epigenetic changes. The fascinating adaptive capacities of plants, achieved without neural structures, continue to be elucidated by dedicated researchers in plant signaling and behavior. Memory, on the other hand, is the creation of neural circuits, pathways forged among neurons. These circuits rely on synchronized activity between key brain regions such as the hippocampus and prefrontal cortex. If these regions fail to synchronize, memory formation and recall can be impaired. What do we mean by neuromodulation? Neuromodulation refers to therapeutic use of neuroplasticity to strengthen or weaken neural connections. By targeting specific brain regions with precise stimuli, we can modulate neural activity to restore or enhance function. Today, a wide range of non-invasive neuromodulation methods are available, including transcranial electrical stimulation, TES, transcranial magnetic stimulation, TMS, neurofeedback, audiovisual stimulation, and focused ultrasound stimulation. These mentioned methods provide insights into brain physiology and offer therapeutic benefits for conditions like cognitive impairment, mood disorders, and sensory deficits. While invasive methods, for example, deep brain stimulation, motor cortex stimulation, to convulsive therapy exist, but this lesson will focus on non-invasive techniques. What is transcranial magnetic stimulation? It is a non-invasive brain stimulation technique that uses electromagnetic induction to generate brief focal magnetic pulses. These pulses penetrate the scalp and the skull to induce electric currents in underlying cortical neurons, modulating neural activity. A rapidly changing current in a coil generates a time-varying magnetic field. This magnetic field induces an electric field in the brain, depolarizing neurons. It may be used in various mechanisms: single pulse TMS, repetitive TMS, high frequency, low frequency, and theta burst stimulation. TMS has focal spatial resolution of 0.5 to 3 square of centimeter, depending on coil design. It has applications in neuroscience, in research, causal brain behavior studies, mapping cortical connectivity, and its clinical applications that are FDA approved are major depressive disorder, OCD, and migraine. It is used also in stroke rehabilitation, Parkinson's disease, chronic pain, and schizophrenia. Its side effects are mild headache, scalp discomfort, and rare seizures. It is contraindicated in metal implants, epilepsy, and pregnancy. And its limitations are shallow penetration and inter-individual variability. Transcranial focused ultrasound stimulation utilizes low-intensity focused ultrasound waves, typically from 200 to 650 kHz, to precisely modulate neural activity in superficial and deep brain regions with millimeter-scale accuracy. Unlike techniques such as transcranial magnetic stimulation or transcranial electrical stimulation, transcranial focused ultrasound overcomes skull limitations by employing piezoelectric transducers to generate focused mechanical energy. This energy interacts with neuronal membranes and ion channels, influencing neural excitability through several key mechanisms. These include mechanosensitive ion channel modulation, cavitation, and bilayer sonophone effects leading to transient pore formation in cell membranes, and neurochemical changes such as reduction in GABAergic inhibition and enhancement of functional connectivity, as evidenced by fMRI and MRS studies. The superior spatial resolution of transcranial focused ultrasound targeting volumes less than 5 cubic millimeter surpasses the centimeter scale resolution of TMS and TES, allowing for precise stimulation of cortical columns and deep brain structures like the thalamus and anterior cingulate cortex. Its ability to penetrate deep brain regions without compromising focality further enhances its utility. Furthermore, transcranial focus ultrasound exhibits a favorable safety profile at low intensities, with minimal side effects typically limited to transient, mild occurrences such as headache or fatigue. Focused ultrasound finds applications in both research and clinical settings. In research, it enables causal manipulation of neural circuits, facilitating investigations into motor cortex excitability, sensory evoked potential, and functional connectivity. Clinically, focused ultrasound holds considerable promise for various neurological and psychiatric conditions, including mood disorders, through targeted stimulation of the prefrontal cortex, Parkinson's disease, and chronic pain management, though further research is ongoing. Optimal therapeutic outcomes depend on careful parameter selection, including pulse repetition frequency, duty cycle, and intensity, which influence the excitatory or inhibitory effects. Adherence to safety guidelines such as FDA limits on intensity and mechanical index is crucial to prevent potential adverse effects. Future research directions include the exploration of combined protocols such as theta-burst focused ultrasound to induce long-lasting neuroplasticity and the development of closed-loop systems integrating EEG or fMRI for real-time neuromodulation. Focused ultrasound represents a powerful tool with the potential to revolutionize both our understanding of brain function and the treatment of neurological and psychiatric disorders. Its ability to combine a high-resolution targeting with a favorable safety profile makes it a promising avenue for future therapeutic innovation. Neurofeedback, in fact, is a facilitating self-regulation of brain activity. Neurofeedback leverages real-time electroencephalography data to provide individuals with immediate feedback on their brainwave patterns. Through operant conditioning, this feedback enables the learning and modulation of specific brainwave frequencies associated with various cognitive, emotional, and behavioral states. The core components of neurofeedback encompass EEG recording via scalp electrodes, measuring electrical activity from pyramidal neuron populations, a feedback loop presenting visual or auditory signals reflecting real-time brainwave activity, and operant conditioning where reinforcement strengthens desired neural patterns. Different brainwave frequencies, delta, theta, alpha, beta, and gamma, are targeted based on the specific clinical or performance goal. For instance, alpha to theta training is often employed for conditions such as addiction and PTSD, promoting relaxation. Conversely, SMR, that means sensory motor rhythm, training is frequently used to enhance focus in individuals with ADHD. Slow cortical potentials training finds application in the treatment of epilepsy and migraines. Neurofeedback demonstrates clinical applications in various conditions, including ADHD, depression, anxiety, and PTSD. In ADHD, for example, neurofeedback aims to reduce inattention by upregulating SMR and beta activity while suppressing theta activity. In mood disorders, modulation of alpha asymmetry in frontal lobes is a common target. Beyond clinical application, neurofeedback shows promise in enhancing peak performance in athletes and musicians by optimizing the balance between gamma and theta frequencies. However, it is crucial to acknowledge the limitation of neurofeedback, including variability in efficacy stemming from the lack of standardized protocols and the time and the cost that is associated with the typically extensive treatment period that varies from 20 to 40 sessions. The mechanisms underlying neurofeedback effects are believed to involve long-term potentiation through reinforcement of specific neural pathways. Ongoing debates exist regarding the extent to which neurofeedback effects are attributable to placebo versus genuine neuroplastic changes. While meta-analyses show moderate evidence supporting its efficacy for ADHD and epilepsy, further research is necessary to solidify these findings and optimize protocols. Neurofeedback is, in fact, a training system in which brainwave activity recorded by sensors played on the scalp of the same person is displayed back to them in the form of a video. When brain activity shifts toward patterns of improved self-regulation, the display progresses and rewards the person with higher scores. If the brain activity regresses, slowing down or stopping, the score decreases, acting as a form of punishment. Through my experience, neurofeedback has proven most helpful in relieving attention disorder hyperactivity and anxiety. It supports the development of healthier patterns of brain activity, and the goal of the treatment is not just to change how you think and feel, but also to improve brain function on a biological level. Neurofeedback helps encourage and accelerate neuroplasticity. Words alone are usually not enough in helping a patient to focus or relax. Simply telling someone to calm down or focus doesn't address the root causes of conditions like anxiety or ADHD. Neurofeedback allows us to communicate with the brain in its own language, that is brain waves. Here I will show a video of one of my patients with anxiety. I asked the patient to make the face of the monitor smile. The more the face smiled, the higher the score became. Through this, the patient realized that to achieve better scores, he needed to release facial muscle tension and relax. Future directions for neurofeedback research include the development of personalized protocols guided by quantitative e.g. QEEG analysis, as well as integration of neurofeedback with other neuromodulation techniques like fMRI, neurofeedback, or transcranial direct current stimulation for more targeted interventions. In conclusion, neurofeedback offers a non-invasive approach to harnessing brain plasticity for therapeutic and performance enhancement purposes. While showing significant promise, continued rigorous research is essential to refine existing protocols and establish robust evidence-based clinical outcomes. Further research should also focus on addressing the existing controversies surrounding its mechanisms of action. Audiovisual entrainment, AVE, is a non-invasive neuromodulation technique employing rhythmic auditory and visual stimuli to synchronize brainwave activity with external frequencies. This process, also known as neural entrainment or the frequency following response, FFR, leverages the brain's inherent ability to synchronize its electrical oscillations to external rhythmic patterns. By delivering stimuli at specific frequencies, for example from 1 to 40 Hz, audiovisual entrainment aims to modulate cortical oscillations associated with various cognitive, emotional, and behavioral states. For example, alpha frequencies are associated with relaxation, while beta frequencies are linked to focus and concentration. The underlying mechanisms of AVE involve neural synchronization, where external stimuli derive oscillations in thalamocortical circuits, particularly within the superior colliculus and thalamus. These structures rely sensory input to cortex, leading to widespread changes in brain activity. Neurophysiologically, audiovisual entrainment has been shown to increase cerebral blood flow, enhance neurotransmitter release, including serotonin and endorphins, and boost metabolic markers such as adenosine triphosphate and lactate levels. Furthermore, randomized AVE protocols utilizing slightly varied frequencies between hemispheres can effectively disrupt hyperarousal in the hypothalamic pituitary adrenal axis, promoting relaxation and stress reduction. Audiovisual entrainment stimulation techniques encompass fixed frequency approaches using constant frequencies and more dynamic randomized audiovisual entrainment methods that employ dynamically varying frequencies. Randomized audiovisual entrainment has demonstrated superior efficacy in treating conditions such as ADHD and anxiety by mitigating neural adaptation. Moreover, multisensory integration combining audiovisual entrainment with tactile or olfactory stimuli shows promise in enhancing attention and memory retention as evidenced by studies. Applications of audiovisual entrainment in neuroscience are diverse. Clinically, it has shown efficacy in treating ADHD, ADD, mood disorders, and migraines. In cognitive enhancement, theta entrainment has demonstrated potential for improving memory recall by synchronizing hippocampal cortical networks, and studies suggest positive effects on academic performance in college students. While generally safe, audiovisual entrainment is contraindicated for individuals with photosensitive epilepsy due to the risk of seizures. Limitations include the heterogeneity of existing protocols, hindering reproducibility, and the potential confounding effects of placebo or non-specific factors such as relaxation from closed-eye rest. In conclusion, audiovisual entrainment presents a promising bridge between sensory stimulation and brain plasticity, offering potentially scalable tools for both research and therapeutic applications. However, further research is needed to establish rigorous standardization and fully elucidate its underlying mechanisms and efficacy. Key areas of ongoing investigation include clarifying the optimal parameters for different clinical applications and developing more sophisticated methods for individualizing audiovisual entrainment protocols. And now, transcranial direct current stimulation. That is the most used method in clinical practice. What is the action of TDCS? Transcranial direct current stimulation acts as a neuromodulatory treatment. TDCS is a non-invasive brain stimulation technique that modulates cortical excitability and promotes neuroplasticity through weak direct electrical currents. Its therapeutic effects in depression and chronic pain are achieved via multiple mechanisms. The first effect is synaptic modulation. TDCS enhances long-term potentiation in hyperactive regions, for example, prefrontal cortex in depression, and restores inhibitory control over pain pathways in chronic pain. The second effect is neurotransmitter balance. It increases glutamatergic and dopaminergic transmission in mood-related circuits while restoring GABAergic inhibition in pain circuits. Another effect of TDCS is upregulation of brain-derived neurotrophic factor. TDCS stimulates BDNF expression, promoting synaptic repair and neurogenesis. And the other effect is neuroinflammation reduction. It decreases glial activation and pro-inflammatory cytokines, reducing neuronal damage. And the most important is the potential mitochondrial enhancement. TDCS has been shown to improve mitochondrial ATP production and reduce oxidative stress, and also enhance cellular energy efficiency, which supports neuroplasticity recovery. TDCS alters neuronal membrane polarization. Anodal stimulation depolarized neurons, increasing excitability and spontaneous firing rates, while cathodal stimulation hyperpolarizes neurons, decreasing excitability. TDCS affects neuronal activity by modulating the membrane potential. Neuronal depolarization is often altered in all neuropsychiatric conditions, and TDCS influences cortical excitability. A neuron fires when it receives a stimulus strong enough to reach its threshold. The depolarization in response to a stimulus may be sufficient to cross this threshold. With anodal stimulation, the neurons affected by the current show a reduction in firing threshold by a few millivolts. This lowered threshold results in more neurons firing in response to incoming stimuli. This will cause a change in voltage, and the changing voltage causes the sodium and potassium channels open, and the exchange of ions will produce an action potential or an impulse. Through long-term potentiation, the suprathreshold spike activity of neurons, enhances the neuronal connection, and increases signaling through postsynaptic dendrites. As mentioned earlier, TDCS has effects on the EEG power spectrum. Here you can see a reduction in alpha amplitude in the frontal region when comparing the active TDCS group to the sham group, specifically during a stimulation over the left dorsolateral prefrontal cortex. In this image, we observe the changes in delta, theta, alpha, and beta power between cathodal TDCS and sham stimulation, the placebo group. Here I present quantitative EEG data from a patient with migraine before and after 6 sessions of TDCS. Prior to stimulation, the patient showed reduced beta and also high beta power. After TDCS, her symptoms improved and her QEEG appeared near normal. TDCS can induce effects in deep subcortical regions also. Here we can see a model that illustrates how TDCS can also induce effects in deep subcortical regions. In particular, we can observe significant activation in the cerebellum in this illustration. Neuronal loss implicates the impairment and disequilibrium of various neurotransmitters in neuropsychiatric pathologies. TDCS modulates neurotransmitter systems, indicating another disease-modifying treatment option, such as dopaminergic, serotonergic, cholinergic, and glutamatergic neurotransmitter systems. TDCS reduces the disequilibrium between excitatory and inhibitory neurotransmitter systems, as was shown by magnetic resonance spectroscopy. The extent to which TDCS modulates behavior is not associated with a single neurotransmitter, but instead relates to the fine-tuned balance of excitation and inhibition. Both anodal and cathodal TDCS significantly change the ratio of inhibitory GABA to excitatory glutamate with individual temporal specificity. The graph shows a significant increase of GABA concentration with respect to glutamate concentration during the second post-TDCS measurement after anodal stimulation. Cerebral blood flow and metabolism and neural network connectivity are altered in almost all neuropsychiatric pathologies. Here we can see the effects of TDCS in cerebral metabolism using FDG PET. Anodal TDCS induces increase in cerebral metabolism and also regional cerebral blood flow, while cathodal TDCS results in a decrease in cerebral metabolism. Focusing solely on the prefrontal cortex when considering the effects of neural stimulation overlooks the broader impact on various brain regions and networks. Neural stimulation techniques such as transcranial direct current stimulation and transcranial magnetic stimulation have been shown to modulate activity not only at the targeted site but also across interconnected neural circuits. For instance, research indicates that stimulating the dorsolateral prefrontal cortex can influence widespread brain networks leading to therapeutic benefits in cognition like depression and tinnitus. This suggests that the efficacy of such interventions may stem from their ability to engage and modulate entire neural networks rather than isolated regions. Moreover, studies have demonstrated that non-invasive brain stimulation can induce changes in functional connectivity across the brain. These changes are not confined to the stimulation site, but extend to remote areas, highlighting the network-wide effects of such interventions. Additionally, computational models support the notion that targeted stimulation can have both focal and global impacts on brain dynamics. By employing data-driven approaches, researchers have uncovered relationships between regional controllability and the broader effects of stimulation, emphasizing the importance of considering the entire neural network in therapeutic applications. In conclusion, acknowledging the network-wide effects of neural stimulation is crucial for fully understanding and optimizing its therapeutic potential. By considering the interconnected nature of brain regions, we can better appreciate how such interventions modulate neural activity and contribute to clinical outcomes. We conducted a study involving 25 patients with dementia in mild to moderate stages and 30 patients with mild cognitive impairment. All participants underwent 5 sessions of TDCS. Among them, 5 patients with dementia received sham TDCS, and 6 patients with MCI also received sham TDCS, that is a placebo control. A standardized Montreal cognitive assessment was administered before the intervention and 1 month after the final TDCS session. We observed a significant improvement in cognitive performance in patients who received real TDCS compared to those who underwent sham stimulation. TDCS can be helpful in cases of stroke. It plays a beneficial role in enhancing stroke recovery, especially when treatment is individualized and the timing of TDCS initiation post-stroke is carefully considered. In stroke patients with hemiplegia, simulation studies show that the brain's plasticity potential is significantly greater within the first 3 months after stroke compared to 1 year post-stroke. Here, we present the MRI of a 22-year-old patient taken 23 days after the onset of a moderate ischemic stroke in the territory of the right posterior cerebral artery. The patient exhibited severe left-sided neglect. The MRI reveals extensive lesions within the right hemisphere, predominantly affecting subcortical regions of the temporal, parietal, and occipital lobes. Left neglect can manifest behaviorally. For instance, the patient may only eat food from the right side of the plate, ignoring the left. You can see here the improvement in patients' drawing test. First is after 1 session of TDCS, and the gain following 5 sessions, indicating functional gains. Here is a video of one of my patients with stuttering. He couldn't talk or read fluently when he first came to me, and we can see him after 5 sessions of TDCS.
ساده شناخت و تحلیل اقتصاد و بازار را فرا روی شما خوانندگان محترم قرار دهیم تا اگر علاقه من بودید با مطالعه آموزش تحلیل و ریزی تصمیم های عمالی
And here, after 5 sessions of TDCS,
دارایی‌ها نیز خود به 2 دسته تقسیم می‌شوند: دارایی‌های فیزیکی مانند خودرو و دارایی‌های مالی همچون اوراق بهادار. اگر در یک بازار دارایی‌هایی که مورد معامله قرار می‌گیرند دارایی‌های مالی باشند، با آن بازار مالی گفته می‌شود. به بیان دیگر، بازار مالی یکی از انواع بازارهاست که در آن خریداران و فروشندگان می‌توانند به معامله دارایی‌های مالی همچون سهام، اوراق قرضه، ارز و غیره بپردازند. بازار اوراق بهادار را می‌توان
as we can see, he showed a very significant improvement.
به 2 بازار اولیه و ثانویه تقسیم کرد.
Neuromodulation techniques are used in clinical practice for enhancing the efficacy of existing medicine, and in some cases that can't tolerate the medicine can be helpful for therapy. The relevant stimulation parameters are electrode placement, electrode size, intensity, duration, and frequency. To set up the TDCS device, the electrodes and the skin need to be prepared. This ensures a low resistance connection between the skin and the electrodes. The careful placement of the electrode is crucial to successful TDCS technique. The electrode pads come in various sizes with benefit to each side. A smaller sized electrode achieves a more focused stimulation of the site, while a larger electrode ensures that a larger region of interest is being stimulated. The effects of non-invasive neuromodulation also depend on frequency and duration of stimulation. Administration of repeated pulses at low frequency or cathodal TDCS results in a reduction in the strength of the twitch, suggesting that excitability has been modulated, whereas administration of a high-frequency pulse of TMS or anodal TDCS results in an excitatory effect. High-definition TDCS has better spatial resolution. It is a form of TDCS where current is applied through a small electrode. The small electrodes are called high-definition electrodes. These high-definition electrodes are small cups that are filled with gel. High-definition TDCS is commonly done with 5 electrodes. If our goal is to target a specific cortical structure, then high-definition TDCS will be used. What will happen if we make the electrodes smaller? Only using smaller electrodes will not localize the current flow. We call the smaller electrodes high-definition electrodes. If we put the small electrodes closer, that will restrict the current flow. And if we use more number of cathodes, we will have higher definition electrostimulation. Future directions involve the development of closed-loop TDCS EEG systems and personalized current modeling to optimize treatment efficacy and precision. In conclusion, TDCS offers a versatile tool for both neuroscience research and therapeutic interventions, bridging ancient bioelectric concepts with contemporary neurobiological understanding. Ongoing research is focused on refining protocols and elucidating its underlying mechanisms. It's important to investigate the role of mitochondrion in neuromodulation. While several techniques demonstrate an influence on mitochondrial function, the extent to which this constitutes their primary mechanism of action remains a subject of ongoing investigation. It is crucial to acknowledge the intrinsic importance of mitochondria in neuroplasticity, irrespective of external neuromodulation. Mitochondria actively participate in synaptogenesis, dendritic spine formation, energy provision for demanding neural processes, calcium hemostasis, crucial for neural signaling, and support adult neurogenesis, thereby significantly influencing cognitive function, while impairments in mitochondrial dynamics result in reduced dendritic mitochondrial content and synaptic loss. Further research into the intricate interplay between mitochondrial function and neuromodulation is warranted, given the fundamental role of mitochondria in cellular energetics and signaling pathways integral to neuroplasticity. Here, I would like to mention that Professor Stavros Balianis always has emphasized on the role of mitochondrion. He has published enough books and articles sharing his own experiences studying mitochondrion by microscope. Professor Balianis explained mitochondrion as a unique organelle that contains its own genome, encoding essential proteins that are major components of the respiratory chain and energy production system. Mitochondria play a dominant role in the life and function of neurons and glia. Grateful for the legacy Professor Balianis left behind. Several distinct transcranial electrical stimulation modalities exist. TDCS utilizes a constant low-intensity current. The effects are polarity-dependent, with anodal stimulation generally increasing and cathodal stimulation decreasing cortical excitability. Transcranial random noise stimulation, TRNS, in contrast to TDCS, that has a steady current, TRNS employs a randomly fluctuating current within a specific frequency range, from 0.1 to 640 Hz. This stochastic stimulation may enhance neural plasticity via stochastic resonance, improving neural signal detection. Research suggests efficacy in improving motor learning, attention, and perceptual tasks. Pulsed transcranial current stimulation, TPCS, utilizes brief pulse currents instead of continuous stimulation. This intermittent approach may mitigate adaptation effects observed with TDCS and facilitate deeper current penetration. Current research explores its applications in pain management, neuropsychiatric disorder, and memory consolidation. Transcranial alternating current stimulation, TACS, applies a sinusoidal oscillating current at specific frequencies, for example, alpha, beta, or gamma bands, to entrain neural oscillations. By synchronizing external electrical rhythm with endogenous brain activity, TACS can influence cognitive functions such as working memory, sleep, and mood regulation. Its utility extends to the investigation of brain rhythms and their roles in perception and cognition. The TES modalities TDCS, TRNS, TPCS, and TACS each offer unique mechanisms for modulating brain function, while TDCS and TPCS utilize steady or pulse currents to alter neuronal excitability. TRNS leverages random noise to enhance plasticity, and TACS targets oscillatory brain activity. TDCS induces lasting after effects on cortical excitability, which are dependent on stimulation duration and current density. Quantitative electroencephalography (QEEG) is a clinically feasible and cost-effective method for longitudinal monitoring of patients following neuromodulation therapy. The potential applications of TDCS are depression, migraine, stroke rehabilitation, stuttering, cognitive declines, chronic pain, vertigo, cerebral palsy, Parkinson, insomnia, anxiety disorders, and cognitive enhancement. Side effects of TDCS are very mild and may consist tingling, itching, burning sensation, headache, and discomfort for about 10 minutes after TDCS. TDCS roots trace back to ancient practices utilizing electric fish for pain relief, and the discoveries of Galvani and Volta regarding animal electricity. Early recorded TDCS-like treatments for depression were documented by Giovanni Aldini in 1801. Lippold and Radfim in 1964 established a link between polarity and mood modulation. The administration of TDCS is straightforward and easy implemented in clinical settings. TDCS lacks full FDA approval in the US. A question that may arise is which neuromodulation technique is best to use. A key recent insight in the field of non-invasive brain stimulation is that each modality possesses a unique neurophysiological signature. As the number of available and emerging techniques grows, a nuanced understanding of their distinct mechanisms becomes increasingly essential. Despite this, few studies have directly compared these methods in controlled head-to-head trials. In summary, neuromodulation represents an evolving therapeutic frontier utilizing diverse forms of stimulation, including magnetic, electrical, ultrasound, photic, and biologic, to harness the body's intrinsic capacity for neural regulation. These interventions aim to normalize or enhance brain network function by modulating neural activity. Ultimately, the deepening understanding of neuroplasticity is poised to drive a transformative shift in brain-based therapies, with the potential to reshape treatment across a broad spectrum of neurological and psychiatric conditions. Thank you for your attention. I look forward to our continued learning together.